It's so lovely to be with all of you and to share ideas from Scotland. It's Gregor Smith and I think we both sort of commented how lovely it is to be here together. Myself as somebody that is just passionate about realistic medicine, design and art, and Gregor who's leading what we're doing as our Chief Medical Officer in Scotland. So I hope that I'll be able to inspire you with a few ideas that have come from alternative ways of approaching problems within healthcare. And when I say alternative, is drawing on the knowledge, skills, and ways of working that come from the arts, from art, from design, from the creative industries, and how we can really draw on what they bring to healthcare. As you'd mentioned, I love asking people what their three favorite words are, things that they're passionate about. And as you'd mentioned, empathy, very high up on my set of words. In the design world that I work in as a healthcare designer now, thinking in terms of journeys of care, not just single points of care, but journeys of care, I think is essential in what we do. And then focusing on outcomes that really matter to people, that reach or occasionally exceed their expectations. That's quite a tough one to achieve in healthcare, but really looking at people's expectations and the outcomes that they're looking for. Marlene, I can't thank you enough for inviting me along today and just being in Paris. Don't you all just love Paris? I love coming here. I'm fortunate I live close to Edinburgh, so it's not far away. It's just, there's something special about Paris. And, love, such an important word to bring into our language and ways of working. Developing new relationships with meaning and creating wonderful learning experiences, which I'm sure we're all going to have over the next few days. So that newfound love and passion for the things that we do, I think we can get a lot of inspiration from the French. The stuff that I'm really passionate about is design. And how might we design care that fits? The how might we is a way of structuring a challenge that I've learned from working with designers, and I find it a wonderful 3 words to use when looking at trying to improve healthcare services. The how, the really practical way of approaching a problem. The might, widening out to a whole range of different options and opportunities, and really looking for inspiration from resources and people that we don't usually work with. And that collective approach to problem solving. Not me, not our small little team, but really throwing it out into a collective response to problem solving. So that image I popped up there is V&A Dundee. I really feel very privileged to live in Dundee. You'd be surprised to hear me say that. But it's a fantastic small city, a population of probably about 150,000, so it's small. But a fantastic art and design college and university, and a museum that is purposely built just to describe the value of design in everything that we do in life. So I've been exploring that world together with our art college and together with V&A Dundee, and really trying to open up and look at the bigger picture of what health and care by design means. Very simplistically, just about everything in our physical, human-made world has gone through a design process. It's been something in a person or a team's imagination, and then a team have actually gone through a structured approach to actually get to that new hospital, the architectural design, the interior design, the graphic design that we use in all our information sources in healthcare, the digital design of some of the services we use. A lot of ours in Scotland, I'm not sure what yours are like, but they could do with a little bit of improvement in the design of the digital stuff that we use. And then service design. And I now work as a service designer in looking at end-to-end journeys for people that become patients. I don't like using the term users. We are all just people that become patients when we become unwell for some reason or another. But looking at how to design that service that would fit individual persons' nuanced needs. Now, this is a photograph taken inside our operating theatres in Dundee. I love the way we use this term in the UK of operating theatres. You know, it's a bit like this. There's a stage, there's drama, there's something that goes on there, actors. There's always a lot of drama in a theatre. But I had the privilege of working in very similar, probably higher spec operating rooms in the United States, in Columbus, Ohio. I did a head and neck fellowship there for a year and learned so much in the way of different approaches to being a head and neck cancer surgeon. Really interesting, when I came back to take a job in Dundee in a head and neck unit, one of the senior nursing team asked me, Rodney, you've had a look at all the kit we've got here. You've just come from the States. What new stuff do you need to do your job? And I thought long and hard, and I had a look at all the fancy equipment. We had really good stuff. We didn't need very much. We needed something I needed something simple, really simple, a tool that I'd used during my time in the States doing a lot of complex head and neck surgery, a pair of scissors. Really simple, but very, very cleverly designed. If you look at that pair of scissors on the bottom part of the image, it's got a blunt end, it's curved, and if you were to pick it up, I wanted to bring one with me because I just wanted to show you one, just perfectly balanced for me to use in the technical aspects of surgery. Simple, useful, safe, and a tool that I used for years as training trainees how to operate safely. Where did that pair of scissors come from? A little bit of history from the Mayo Clinic. And these are curved Mayo scissors. And if you speak to any surgeon around the world, they'll know what you're talking about if you describe these. Designed by the two Mayo members of the family and instrument makers who were really good at making high-quality equipment. So simplicity, simple design, things that we take for granted, are often super valuable as tools for the work we do. This photograph is taken from the streets of Dundee, from the city that I live and work in and have been working in for the past 30 years. Unfortunately, I think it's a city that is affected by a high level of poverty, deprivation. We've got food poverty. We've got a lot of people who are homeless. We have a lot of refugees, particularly from Ukraine at the moment. And it's a very challenging world for people to navigate, particularly when they try and navigate our systems and our services that we've set up in our hospitals. They really don't fit their individual needs very well. Having worked in healthcare for a long, long time, I repeatedly have had the feeling that I'm working in a factory. I don't know if any of you experienced that you're part of being on a conveyor belt and a process. I think our systems that we have in place are needed. We need rules, we need standard operating procedures if you're working in a laboratory where there are highly dangerous chemicals that you're working with. We need protocols to guide team working between different parts of an organization. We need the guidelines that we have for the different disciplines that we work in. The challenges I've found with a lot of the guidelines we are given, that they are designed very much for certain types of people and designed specifically, usually with one disease in mind. Now, in the real world, most of us face people who've got complex, multiple, different diseases, and the guidelines don't fit perfectly and have to be interpreted very, very carefully in what we do. We are measured by metrics, and in the NHS in the UK, the metric that we get measured by is waiting times. How long, I'm sure you would have seen, the UK does have problems with waiting times to be seen. That's the metric that is used. The metric that we use in head and neck cancer as an oncologist is 5-year survival rates. I've never really warmed to that whole concept of 5-year survival rates. What is that survival really like for some of those people, particularly towards the end stages of their lives? Very little in the way of measurement of their quality of life and their experience during those survival years. We're all, I think, faced by efficiencies and trying to get as much out of our healthcare systems as possible. That's a challenge that I think I've faced just about every year in the NHS. Is we've got fewer people to do the jobs, we need to get more people through the system. How are you going to do it? So that feeling of being in a machine, and really I would suggest we've overcomplicated things and we've made them very impersonal as a consequence, looking at that pure industrial model of healthcare. I put this up really in memory of a patient of mine, Raymond, and this photograph was taken a good 15 years ago in our clinic. We're both exactly the same age, within a month, born in 1960. And Raymond presented to me, referred to me, with a lump in his salivary gland, his parotid gland. Now, the vast majority of these are benign, innocuous, pleomorphic adenomas. You do scans, you do needle samples, you take them out, and everything's fine. Unfortunately, Raymond's salivary gland swelling wasn't fine, and it was a rare, highly aggressive malignant cancer, which despite further surgery, radiotherapy, chemotherapy, he died just a few years after that photograph was taken. And I can assure you, on that journey as a clinician, the physical stuff was easy. The operations, I think most people think that you're a head and neck surgeon, that operating must be your real challenge, and complicated anatomy and complicated surgery. I would suggest that is the easy bit. That is really the easy bit, because you're trained, you simulate, and you do those procedures over and over. They're easy. The emotional, breaking bad news and taking people on a journey in the context of a disease, particularly that doesn't have a cure, is very challenging for both the patient and you as a clinician. And I'm sure a lot of you that help people with complex long-term problems that don't have solutions would understand exactly what I mean. And then the complex social and cultural consequences of disease that unless we ask and investigate and really get into people's lives and understand them better, we often miss. So what other systems might improve this industrial model? What could we add? Not necessarily do away completely. We can't do away with the industrial model, but that we can maybe get inspiration from elsewhere. I would suggest, and this might sound a little bit off the wall, but I would suggest that we step back and really gain a lot of our inspiration from nature and the more than human ecosystems that exist in our world. We are part of nature. We're not separate from it. We have separated ourselves through our industrial model, through our cities, and through our ways of living and working. I spend a lot of I've retired from clinical practice 2 years ago, and I now spend a lot of my time out and exploring the opportunities to use outdoor spaces as a way of preventative medicine. Trying to get children, families, outdoors, gaining the physical and emotional well-being of doing stuff outdoors. So that's what I do day in and day out. And we are now starting to see the huge benefits that come through of nature connectedness. Nature connectedness is super important to all of us as human beings. And I think we really can be inspired by nature. If you look at nature and get right down, we've learned so much from particularly plants and all the chemotherapeutic agents and the drugs that we've all gained from plants. We can look at their habitats and how they all connect and communicate. Those relationships of symbiosis and mutualism rather than relationships of competition and that slightly competitive world that we're in. Nature has fantastic feedback systems and a lot that we can learn from them. When I look at a lot of our healthcare systems in the UK, I think we can improve significantly on some of the feedback mechanisms that we have in our care systems, and really opening up a conversation of what I describe as care environments, really looking at the bigger picture of our environments as being caring for us as human beings, but also the roles that we have in caring for nature and our environment, and all the challenges we face with losing biodiversity. So this complex and adaptive ecosystems, I'm sure quite a lot of you might have seen this. It's a whole line of thinking and work that is coming through more and more, getting inspiration from nature and ecosystems and that way of working. And that's where I think we can really start to strike a balance. I've added in really this concept of quality and quantity. We're very good, most of us, at measuring quantity. We can gather data, stats. That's the stuff we're very good at. We're not that good at measuring the qualitative elements of human experience. And I would suggest even designers are struggling a little bit in that world. It's not just all of us that work in healthcare, but human experience. How do you measure that? It's vitally, vitally important, that qualitative, emotional element of being a human being. Very, very important. So quantity and quality. And I think we really need to put a lot of our time and effort into looking at ways to measure quality better. Wouldn't it be lovely if we could actually fuse these two and get away from this separation of quantity and quality and bring them together and gain the power of the two if given an equal share, and bringing in that biological, biometrical, and biographical language and way of thinking to what we do. I look around for inspiration, and just out of interest, do any of you know of the work of Neri Oxman, MIT? So if you're interested, this is an infographic that I have pasted on my wall just as an inspiration for thinking. Neri Oxman is an architect that has worked at MIT for years and now runs a private company in the States. And I just love the way she thinks and brings nature, the arts, design, and creativity into everything that we do. So on the left side of that image, the art and design and where this plays a part and where I think some of the real gains can come from. The real gains through art and design are ways of changing culture and perception, looking at ways to change people's behavior and motivation. Really, really important, particularly in disease prevention and in chronic disease. And then looking at much better ways that we can actually utilize our resources and how we share information better. So that left side, I think, is where we need to spend more time. We're really good at the science and the engineering and do that well. But let's try and spend more time looking at the value of the arts and design and the creative sectors. How many of you, just out of interest, know much about realistic medicine? Just a quick show of hands. Yeah, brilliant. It's really interesting. I've worked as a doctor for many years, and in 2015, I describe my world as a clinician as pre-2015 and post-2015. Somebody and a team, our Chief Medical Officer in Scotland, Catherine Calderwood, and a team, including Gregor, am I right, Gregor? You were very much part of that team at the time, really stood up and challenged us as the doctors, to completely pause and rethink the way we did things. Realistic medicine is very, very similar to care that fits. And I've gone through an interesting exercise of asking ChatGPT, compare realistic medicine with don't you use ChatGPT all the time? Yeah. So there's so many similarities. I think we can really learn and share resources between the realistic, what I describe as a realistic medicine movement in Scotland. This is something that has become a real movement. In Scotland, we have realistic medicine teams in every health board. We teach realistic medicine to our students. It's really become a very, very important component to what we do. The key components, I'll go through them just very briefly, is changing a style to shared decision-making. It's looking at much better ways to personalize care and putting people at the center of a journey of care. Looking at ways to avoid harm and waste. Our health service, and I'm sure all our health services, are very, very wasteful. And I think if you look at the data, it's anything up to about 20% of what we do doesn't actually bring much value to what we do. Plus, if you look at what the waste we create globally to the planet, with all the plastic waste and everything else we generate, drug waste, you name it, we are very, very damaging part of society. There's a lot of harm and waste that unfortunately gets done to us, particularly towards the end stages of life. And I reflect on my own family, my mom and dad, and a number of members of our family, that if I look towards their last 6 months or year of life, there probably were a lot of unnecessary things done to them. More scans, more drugs, more operations, you name it. But in the end, less might have been more. I'm not sure if any of you have had that sort of experience in life, that perhaps a little bit less would have been more in a lot of situations. Reducing unnecessary variation. I think variation is a good thing from a perspective of innovation, but unnecessary variation, and where there are really sort of high levels of variation within a specific management of a disease, that needs to be looked at and investigated. There might be good reasons for it, but we have to try and avoid outliers and postcode lotteries that we sometimes have in parts of our service provision. Managing risk better, that's what we paid for. That's what I always say to my med students. That's what I'm paid for as a consultant surgeon, is with my knowledge and expertise, is helping you as the patient really manage risk as best we can. It's never perfect. And Marlene, as you'd mentioned early on, it's messy, it's never perfect, but you really try and manage that to your best ability. The last bit on the infographic really inspired me, and when I read Realistic Medicine for the first time in 2015, I had an emotional response to reading this, because this is the first time that a fellow doctor within our health service had stood up and said, we want you to be an innovator, we want you to be an improver, we want you to be part of this team. So this challenge to the way we think and act differently, I think, is super important. We always need to challenge ourselves, but it's a real opportunity to improve and innovate within our services. So where do I work? I work a half day a week at the moment, still in our medical school in Dundee, and I'm part of a small team of 10 people. We call ourselves the Healthcare Improvement Team, and we offer month-long modules for all our medical students. So if you're a med student in Dundee, you have to do a healthcare improvement month-long module. That's part of what you learn at med school. And you can see across the board there the expertise that we have in our team. It's quality improvement, design, realistic medicine, sustainability, service working, equalities and diversity. That is our team. And our team offers modules to students. I thought I'd introduce you to our team. The team that I'm actually with, I unfortunately can't be with you for the rest of the week because I've got a team of 12 students with me. And they're doing a healthcare design module with me, looking at understanding design and then actually using design as a method. So during the week, these are some images I took over the past 2 weeks. We've been in the V&A learning from a teacher who teaches design to teachers in and around our primary schools and high schools. We've been out working in industry with a company called Kids OR that are designing, for want of a better term, a flat pack hospital, a maternity hospital, 50-bed hospital that is being designed to be taken to Gaza. So this is a real big project going on in Dundee at the moment, but our students actually went in and engaged with that team. There's an outreach of NASA. You'll see NASA on that, where NASA are experimenting with a device that is based on ceramics that can generate medical-grade oxygen from room air. And as a device, it could be taken out to a place like Gaza, areas where there are disaster zones around the world, and you can actually generate oxygen on site. They've been meeting people that work in the third sector, the voluntary sector, charities. I never know how to describe that sector properly because it's different wherever you go around the world, but actually learning from that really important third sector in our societies, which a sector that I suggest we probably ignore too often, and we could do a whole lot more with our voluntary and third sectors. And then taking the students out and engaging with real people in areas of deprivation, parades, different ways of meeting young people, and then teaching them how to prototype. So those are two of our students in that bottom right-hand corner who are learning how to make simple prototypes as part of a project that they'll present. So I wanted to do a quick imaginary exercise with all of you, if you don't mind. If you could just close your eyes for a second and just imagine you back and you're a student. You're back in that first day of being a student wherever you've started your careers. You can open your eyes now. How did that feel? Was that fun when you were a student? It's probably a mix of fun and quite a lot of hard work and studying that you'd needed to do to get through all your exams. But I wanted to take you on a whistle-stop tour of putting yourself in the shoes of the students that I'm teaching at the moment. So please stay in that imaginary mode. You're in my clinic, and it's day one. Our clinic is not a clinic. It's in the Botanical Gardens little shed where we meet and do most of our teaching outdoors and in outdoor spaces. So, hello, my name is Rod. I'm not doctor or mister or professor, all these titles that we have. For the next month, we're going to be together and we're going to be working as a team. And for that team to work effectively, I'm part of the team. I'm one of you. I'm going to be learning a lot from you, particularly as a young person. There's a lot of stuff we're trying to design that is for young people, and I'm going to learn a lot from you during that month. And I'm obviously going to teach you as much as I can in a short space of time. These are 3 books that I would suggest you maybe consider reading during your module. One is a great book on empathy, another great book on change by design, and a fantastic book on design for disability and how we can actually enable people. How many out of interest in the audience here might have read one of those? And yeah, good. So that's your reading list. I'm going to give you my email address and phone number. We're going to set up a WhatsApp group, and we're going to communicate over the next month as we are all immersed in a design challenge. These are the intended learning outcomes. I'm sure all of you that teach have to go through a process of intended outcomes. These are creative outcomes that I'm going to challenge you a bit and get you out of your science-based way of thinking you've had so far at med school. You're in your final year at med school now. You've got a lot of that science behind you. But I'm going to teach you about realistic medicine. I'm going to introduce you to design thinking. I'm going to teach you a few design methodologies. A lot of that is very visual, and it uses maps and prototypes and things you maybe haven't used before. We're going to give you a healthcare challenge that is in the real world. This is not something I've made up. It's one that has been given to me by an organization that we work with. At the end of your month, you're going to need to create a poster that really distills down the key points of ideas that you brought to this challenge. You're going to have to stand up and present to the team that have set the challenge to you. So you'll be standing up like I'm standing here today and presenting your findings, and you're going to need to do a 1,000-word reflective report on what you've learnt over the month. These are a few key words and ways of working that I hope you'll learn over the month. You'll learn the value of compassion, and I can't stress this enough, that my take on what compassion means is empathy in action. You've been empathic, and you've acted on that. You've actually gone out and done something for somebody. And the huge benefits to the person or the family that you've helped, but the huge benefits to yourself as a person. And for those of you that have not read the book Compassionomics, I would suggest it's well worthwhile reading, because it articulates exactly what I've described, the two-way benefit of compassion. We'll teach you quite a lot about equality and equity. We'll teach you the value of kindness. We'll get you out into communities and really look at that primary care, preventative health strategy that I think we all need to rethink and reinvestigate more deeply. We'll teach you a little bit about leadership and leadership styles. We'll put you into teams. So there are 12 of you here today, and we're going to divide you up into 4 groups. You're going to be working in groups of people that you've not usually worked with. So if you're here with a friend today, you're not going to be working together with them during this module. And you're going to have to learn to work with different other fellow students that you maybe wouldn't gravitate to normally. We're going to introduce you to other disciplines out with healthcare. So you're a doctor. This project, you might get some help and advice from your nursing colleagues and from your allied health professionals, but we're going to introduce you to artists, to designers, to gamers, to people that don't normally work in healthcare. And they might become part of your team. So your timetable for the next 4 weeks, we're going to use the UK Design Council Double Diamond. Just out of interest, how many of you have seen the UK Double Diamond approach? This is an approach that we use a lot in the way we work as healthcare improvers. So over those 4 weeks, the first week, you're going to learn a lot about design. You're going to discover a whole lot of design. You're going to be given your design challenge. Your second week, you're going to narrow that down and say, what are the really important components? What are the real key elements that are coming out that I can take with me to develop and deliver a solution or set of ideas at the end of my module? So this is your very busy timetable. On the left-hand column, you'll see that all the events and places we're going to learn are not in the hospital. We are out in other parts of society. That's where we'll be meeting. Every day starts at 10 o'clock, and you can see the students just, oh, thank you, because most days they start a lot earlier than that. And that's been done purposefully. So this can give you a bit of time to read, and I want you to come to these modules inspired, awake, and not in a rush. You're going to be meeting a wide mix of different people in your different modules, in this part of your course. And I've given you a set of learning resources. I would suggest that the first one to have a look at is a wonderful short film created by the Cleveland Clinic on empathy. And how many of you have ever seen that or used it? It's fantastic. It's a wonderful tool to give people an understanding of empathy. The Design Council website, we're going to steer you to another fantastic resource if you are interested in design in your careers. So that's your first week, super busy with a lot of learning opportunities that we'll give you. Your second week, there'll be slightly fewer. Your third and fourth week is going to be up to you. We're going to be there with you and helping you, but that bit is going to be up to you. You've been given a design challenge by a real organization, the NHS Tayside Children's Charity. This is a charity that has a lot of money, and the way they work is they give money to other charities. So in other words, they're a wealthy charity, and people apply to them for money to do project they're doing. And they want to do better, and they want to do better for children and young people. So the design challenge we've given you is how might we improve the lives of children and young people in Tayside. Tayside is the region that we work in, and that's an area that covers probably 400,000 patients. That's our health board. So I'd leave that question with all of you, because I'll come back to it. All of you that are really here in the audience today, not the imaginary audience, is to think about how you might improve the lives of children and young people where you're living and working. We'll come back to that one. Now, as a student, a lot of you would have learned some of the basics of realistic medicine in year 2 and year 3 at medical school, but I'm going to just share a few elements of realistic medicine that I love and I think are really powerful ideas to take forward with you. I grew up in a world where we used the terminology of evidence-based medicine. I would suggest that that is a thing of the past. We need to talk about evidence-based practice where the patient's values and preferences are put much higher on our thinking and ways of working. I've noticed, even in the new realistic medicine reports that have been coming through, that there's even a better way of describing this as evidence-informed practice. And Greg, I'm not sure when that came through, but it's genius, because it's all about how we share information better. So moving from evidence-based medicine to evidence-based practice, and then really on to evidence-informed practice. These are a few visuals that we'll teach you a lot more about during your module. The real importance of kindness. Kindness can be infectious in an organization, and I'm sure you as students might have been to wards and parts of our hospital where there has been quite a kind, caring environment, and you can almost feel it just after being in that unit for a short period of time. But I'm sure you might have experienced unkind elements of our healthcare service where people are quite aggressive, quite hostile, and quite honestly, I would describe it as bullying is the style of working. And those are quite scary places to go into. Just being aware of the real importance of kindness. At a personal level, I've worked in some very unkind units in different countries, and I won't name the units, but I can tell you the effect has had a detriment on patient safety. We have hidden information from our seniors through just being absolutely terrified of the response that we would get from them. And that has happened in 3 countries that I've worked at. Unkind environments are dangerous environments. We'll teach you a little bit about changing your language and ways of approaching conversations with patients that you'll be working with, and using terminology like what matters to you, rather than what is the matter with you. Very, very different. And a much nicer way to open up as a loose, open-ended conversation with people where you can try and get into their physical needs, their psychological needs, and then trying to understand their social context and maybe move on even more deeply and understand their cultural context. And those social and cultural contexts, I would suggest to you, are super, super important, particularly when helping people with chronic disease and long-term illness. Now, I'd suggest you all have your bran for breakfast. All right, do you get that? Okay. This is genius. And I interestingly enough, learned bran when I worked at Ohio State at the Arthur James Cancer Institute. A guy called David Schuller, who was the professor that taught me, he always brought nothing, not acting, not doing anything, into every consultation he did in the clinic. Now, David Schuller had people flying from all over the United States to come and see him because he is one of the highly ranked head and neck surgeons in the United States. People would travel 4 hours to come and see him. And David, no matter who you were, would go through the benefits of an intervention, an operation, or radiotherapy. He'd spend quite a lot of time on the risks in some detail, and he would definitely bring alternatives to the conversation and think, look, there might be, why don't we ask somebody else from a different discipline or from a completely different field to look at this problem, because I don't really have the answer. But let's just always keep in our minds that there is an option to not intervene. Not that we're not caring for you, we will still care for you, and we'll set up care for you, but not intervening from a medical perspective. And that, I think, is so important in what we do. In recent years, and I think, Gregor, you've really brought this to the table, is bringing this balance of biography and biology into the conversations. People's stories, their back history, everything that makes them a human being, is valuing that in the conversations we have. And that is a key area that realistic medicine... Hi, come on in. Those little steps make quite a noise. That was, yeah. So this balance between biography and biology, and this balance between science and art and that conversation, I think it's fantastic that we're bringing this to the conversation and what we're doing. The two areas of realistic medicine that I think really are dear to my heart are the first two at the top of the infographic. They're changing our style to shared decision-making and building a personal approach to care. And that really fits everything that you're doing as a care that fits organization. And bringing another language that, to the conversation and thinking of how we help each other. And this concept of helping relationships, I think, is a different way of framing things and quite an important one to consider. Relationships are two-way things, and a doctor-patient relationship does have effects, particularly emotionally, on both sides of that relationship and that conversation. I can assure you, after doing a head and neck cancer clinic and having to break bad news to 4 people in a morning, I go home with quite a lot of emotional baggage at the end of that day. So helping relationships is it's a two-way way of working. I'm really inspired by Edgar Schein and his work done in the 1960s, working in industry and bringing a lot of psychology and ideas to innovation in MIT. And just out of interest, how many of you use Edgar Schein's sort of way of thinking and working in what you do? He described a lovely concept of helping relationships, 3 ways of thinking, and I think they're very relevant to healthcare. And how might we help each other? Helping is the key word here. We all know about doctor-patient relationships and that shared decision-making in what we're doing, and that, to me, makes up the bulk of a lot of the clinical work that we do. That stuff where we can quickly solve a problem, provide a solution to somebody's problem. Occasionally, we have to step up and be the expert, and this is particularly important in situations of acute changes. So in other words, acute trauma and acute intervention, the doctor, the nurse, the allied health professional, no matter who you are in that role, does, for that period of time, actually have to step up and be the expert and take over to a certain degree. But that's only really good for the management of acute interactions. The far better model that comes through Edgar Schein's thinking is putting the patient as the expert. They're the expert in their own lives, their patient experience and their lived experience. And there's so much more that we can do through taking an asset-based approach and helping them in the long-term management of their condition. So me, we, and you is my oversimplification of this. Is the we is our day-to-day shared decision-making. The me is where I take over as the healthcare professional. And you is where I empower you to take care of yourself and that I'd be there as your supporter. I've had to be a carer in recent years for both my mom and dad towards the end stages of illness. And that was a really interesting exercise. I had never experienced or quite understood the role and the value and the importance of care, of being a carer. And I would suggest then when we thinking about relationships, really to start thinking that it's a relationship of us as professional, of patient, and someone else. Who's missing? It might be a partner, it might be a family member, it might be a friend, but we all need a third person in a lot of our long-term care. And that third person can be with us, come to clinics with us and be there as just as an external pair of eyes and ears to support us, and can actually be there even in acute situations. And I make a real effort in acute trauma to try and let the relatives know immediately what's going on, is that your loved one is in a serious condition, but we are going to the operating theatre now, and I'll be in touch with you. There's somebody else there that is always a third person. And I would suggest that we need to start thinking in terms of triangles of care. That image, I put my dad in the middle. In my times, I spent caring for him, of getting down to food, eating, toileting, you name it, making beds, turning him over at night. Those roles that are so, so important. And putting the person's resilience at the top of our thinking, bringing in our clinical support as best we can, but really valuing the carer a lot more. And if you look around, you'll actually see these care triangles popping up more and more. These are a few organizations in the UK where they are using triangles of care as a way of thinking in mental health, care of the elderly, chronic disease, just a good mental model that always brings the carer in. I was going to suggest two really good models of where triangulation works extremely well. Have any of you heard of FICare? Does anybody work in neonatal intensive care units at all? Just out of interest. It's called Family Integrated Care, and it's a world phenomenon now. I think it started in Canada, if I'm not mistaken, but I went to the FICare conference in Glasgow last year, and this is brilliant. It brings usually mom, it brings dad and the family to the table as equal partners in decision making. So in our unit, that's an image taken in our Ninewells NICU, is mom as an equal partner every day on the ward round. She has a fob, an electronic fob, to get into the unit any time of the day. She has a place to sleep if she needs to, if she's been with her young one for the night, and she is on the ward round and is a valued person on that ward round. And that's something that I think we need to do more of, particularly in care of the elderly. Mental health, just about everything is really valuing these important people as being part of the decision-making that goes on our ward rounds. PAMIS are an organisation in Scotland that provides support for people and families that are affected by profound physical and neurological disorders. So it's the likes of that little boy in a wheelchair with profound disorders. Just out of interest, Google PAMIS if you're interested. They've got some fantastic resources for carers, and they've created a care passport, and I thought this was absolutely genius. It's done on PowerPoint. It's done with the carer, mom and dad, or somebody else together with the cared for, and all the nuances of that person's life are put into a PowerPoint presentation. You can embed videos, you can embed slides, you can put in, I like eating carrots, I can't stand peas. When I have a shower, let me take a little video, this is the way I like my head tilted during the shower. All those nuanced things can be put into a care passport that can then be shared with whoever's going to be your next care worker or your next carer. So you don't have to go over and over the same thing again. It's yours. It's been created by you. I hope you like my sunflower. This is something I've designed together with one of our medical artists. And I think this really brings together all these circles of care. I love hexagons. We beekeepers, and so I just love hexagons. So I thought, how can we bring this in? And putting yourself at the center of all the circles of people that we have in our lives that support us. We have our anchors, our immediate family that are right there. We have our friendship groups, really, really important. We have our associates, the people that we work with. And then we have the exchange, the areas where we do business and spend money on what we need. We have nature, and we tend to neglect and ignore our connections with nature. And we need to connect. We all have different belief systems and that bigger picture of where we fit into that sort of more cosmic element of life. So this is just a little slightly playful sunflower that I think you could all maybe look at and map out. We'll spend a lot of time looking at sustainability during your module. We'll get in and see some of the stuff that's going on in Scotland. There's a group called Design Hopes that I'm part of at the moment. They're really looking at healthy organizations in a place-based ecosystem, and it's all about design. These are designers that are trying to improve what we do. So I've forgotten to tell you what design is all about in healthcare. So what do designers actually do, and what will you do during your next few weeks working on that challenge that we gave you? I'm going to ask you to put people first in everything you do. Money will be important. There'll be a whole lot of other things that are important, but as a designer, try and put the people first in what you're designing. Just some little bits of inspiration from other people. I love this concept. You know, design is really practical. Design is how things work. It is important how things look and feel, and beauty is important, but how things work is super important. Design is constrained, and when we design real-life projects, we have things that are desirable, but we have to look and make quite sure that they're feasible and actually will fit in the real world. And super importantly, they have to be viable from a money perspective. Not just a short-term fix to something, but something that's going to be sustainable and continue long-term. Design is all about emotion, and very important is to bring that emotional feel, that human experience to what we do. It took 20 years for somebody to ask me as a surgeon how it feels to be a surgeon. And that was asked by a friend of mine as a designer. I was shocked. Nobody had ever asked me. Just, you know, what is the experience? What is the emotional thing of being a healthcare worker? And this stuff's important. So the question I gave you earlier on about how we design better services for children and young people, the natural reaction that I think most of us will take is that we will Google things, we'll go to ChatGPT and say, well, what are the problems in our community and our environment? And then we'll maybe come up with a few solutions and ideas. We'll go out and design something for them. The better thing to do is to actually step back and go and speak to real people. Get out into communities. It's not rocket science. It's super simple, but we really don't do it often enough. We'll give you tools, and we'll give you a toolkit that has a mix of quality improvement tools and methods and design tools. And this is just the mixed approach that we use in Dundee. At the top are a range of different QI methods. A lot of us are well versed in QI, but at the bottom there's a set of methods that are drawn from design. And this is a PDF that I can share with you if you're interested. So if you're interested in the mix of these, more than happy to share them with you. These are just the ones we use in Dundee. You as a student are going to get out onto the streets of Dundee and meet real people. That's pretty scary. You probably haven't done that before. You've met people, but they've been in clinics in that environment where the power, if that's the right term, probably sits a little bit more with you and the doctors. But we're going to give you tools. We're going to teach you a little bit of ethnography and observational skills of going out and looking at an environment and the objects that are in that environment, then looking at who the people are that are in that environment, and then most importantly, writing down, documenting, taking photographs of the important interactions that are going on and the activities that people are doing in that environment. So ethnography, observational ethnography, a really powerful tool that you can take with you. We'll teach you how to use an ecosystem map, and this will draw on personas, or putting a person at the center of your thinking. This is an ecosystem map that we've created for healthcare workers. You get a whole lot of different ecosystem maps. This one is designed to take into account 4 key elements: physical, psychological, social, and cultural. Just a lovely checklist when you're with people. We'll also teach you to think in terms of journeys and journey mapping, and how you can take somebody through different stages of disease. That image on the left is of a patient with insulin-dependent diabetes sitting in a room with a group of students at a previous module, really learning about his journey and all the interfaces he's had with the products that he uses. Endless devices, how he found them, how he uses them, when they go wrong, how he can be supported. So an empathy map, a really useful tool. We'll also show you a map called a lived experience map. And this is a nice way to really get out and understand the nuances of people's real lives. The map we're showing you there is one used with people with light sensitivity disorders, so rare, horrible conditions that if you're exposed to light, your skin erupts and you run into all sorts of trouble. So sitting down with people with these conditions and seeing how they affect them in getting to school, how they affect their communication with friends and family, with their GPs, their general practitioners, how that affects them when they go on holiday, things that we sometimes forget about. And then what their relationships are across that chasm with the healthcare service and academia. So a lovely way to map. So we'll give you these, like you to print them out in A3, so it's nice and big. When you sit down with people, this is just a visual way of understanding people better. All of those tools will be useful to you during your design module, but they'll be super useful to you in your clinical practice, just as ways of thinking and working. And there's one final map we'll introduce you to. It's a thing called an ecosystem map. And what an ecosystem map does, it gives you the ability to zoom out and really look at the bigger picture of a healthcare system and service. And on the left-hand side, in the blue, look at the geography, look at the people, look at what the people's needs are, and look at the feedback systems that are in that ecosystem. On the right-hand side, look at all the policies, the governance, the rules that are there, all the documentation that is there. Look at the peer learning groups that might support that particular condition, and then look at what educational methods are in place to run that service. At the bottom of your map, in the green, you'll look at the team that provides that service, the people, the environments that they work in, and the kit that they have to actually do that. And then, once you've understood that ecosystem, you'll be able to get an understanding of that person's journey, how you can try and optimize their journey through that system. So when you come to present your work to us at the end of your module, I'd like you to stand up and present slides to us that tell stories, that bring images, maybe even video clips into the conversation, bring in a lot of qualitative information, and balance that with the quantitative data, graphs, and statistics that are super important. So try and do that. I'd suggest that you don't come up with finished products at the end of this, because I'm sure you'll be terrified to try and come up with something that is finished. In 4 weeks, you can't do that. But we'd like you to come up with some prototypes. And interestingly enough, just stepping out of this, one of the students phoned me last night and said, "Do you mind if we bring a model?" So they have actually made a model that they're bringing to explain what they're going to do for young children in Tayside. So just a quick exercise for all of you. If I gave you the challenge, how might you improve the lives of children and young people? Any quick thoughts? What are the real challenges young people face in your worlds? Poverty, huge. Sorry, I missed that. Mental health, huge. Yeah. Too much screen time, mental health. Yeah. Access to education, yeah. So learning opportunities. Yeah, those are, yeah. Advocacy, completely. Yeah, particularly for marginalised groups, advocacy a huge thing. So I'll tell you what the Dundee students have come up with, and they've literally, yeah, you had one more there? Quality food, yeah, food. So food poverty being a very real challenge. Those are the four that the group of med students are teaching as we speak. So I'm leaving tomorrow and going back. They're going to be presenting ideas in those neurodiversity, mental health, screen time, all that sort of thing, a huge challenge. Boredom. Now, I wouldn't have thought of boredom, but so important. And they, what can we do to try and get young people outdoors and away from their screens? Literacy and learning opportunities, massive. And then culture, diversity, and trying to bring people together. The students are designing a festival where we're going to bring people together from all different groups within our city. We have refugees, we have, you name it, people from all over, to come together as a community. And I think communities are really the way ahead for a lot of the things we do. So, an invitation to all of you. If any of you want to come to Dundee, please do. Between now and February, the V&A in Dundee, the museum, have got our exhibition on sustainability in healthcare running, and I'd be delighted to take you on a little tour of all the different elements to design hopes. And thank you to all of you for having me, and I'd be more than happy to share a few questions.